So let's go ahead and get started. So in terms of our first panel, and I will introduce Cherie, and then we'll call up the panelists after that. By the way, I'm not going to spend a lot of time on bios, but the bios are within the app. So if you're curious about more information about who each of our speakers are, it's all within the app as well. So I would like to introduce Cherie Lowe, and Cherie is our Vice President of Behavioral Health at the California Hospital Association, as well as our primary legislative advocate for hospitals serving individuals with mental health and substance use disorders. And if anybody knows Cherie, you couldn't find a better advocate for your behavioral health issues at the state level. So let me go ahead and call up Cherie. Thank you.
Good morning, and I don't know if it's a curse or a blessing to be known as the best advocate for behavioral health. I have been with CHA for 15 years and have watched the field of behavioral health transform, and I'd like to say for the better. And in some respects it is for the better because everybody is talking about behavioral health. Sometimes we're talking about it out of both sides of our mouth, and sometimes people are talking about it with disdain. So I'm going to just give some opening remarks today about the state of the state a little bit, and then I'll introduce our distinguished panel that are going to put a very positive spin on some really good work that is happening in our state. I also know that the board met yesterday and they had a very robust discussion. I heard that they talked about behavioral health for over an hour. I will tell you that 10 years ago, that would not have happened. So when I talk about progress, that's one of those steps of progress that I think we are seeing, not only in California, but nationwide. Structurally today, the three panel members are going to talk about three very separate programs. So I'd like to open up Q&A after each of the presenters, and then we'll do general Q&A at the very end of the program. My statewide comments are this. So there are some very undisputed facts about behavioral health. Our delivery system is dysfunctional. The vast majority of people in need of treatment don't seek treatment. There is an increased number of suicides, both completed suicides and attempted suicides. There is an increase in our homeless population. And there is an increase in the number of people in our prisons and in our jails that have a diagnosed mental health condition. Does anybody dispute that? I can't find anyone that will argue with me on any of those points. There's some agreement, though, that prevention and early intervention works. There's even some studies that are starting to prove that. To me, that's common sense. But I think we need some scientific evidence to bring some people along. The other agreement is that the least restrictive level of care is the most desirable level of care. And there's also agreement that stigma reduction is happening. I fortunately have some friends that have some teenage children, and it's becoming almost a status symbol to say, oh, I can't go to that party because I have an appointment with my therapist. That's good news because we're not keeping it sort of in the closet anymore. I think social media has a lot to do with that, and there are new apps coming out every day to monitor your mood and to talk to a therapist online. And that's going to change the discrimination that we're seeing and the stigma that we see behind people with mental health conditions or substance use disorder conditions. There's also disagreement out there about how do we solve the problem that we're in. You know, everywhere I go in the non-hospital setting, people say, well, we just need more psych beds. We need more inpatient psych beds. You know, I don't know that I agree with that, and I'll tell you why. We have hundreds of patients today sitting in our inpatient psych beds that have passed their acute stage of their illness, and they need to be in a post-acute level of care. We don't have an adequate array of post-acute levels of care. Do I agree that we need more psych beds in some parts of the state? Yes. And do I agree that we need more psych beds for certain populations? We have less than 100 beds in this entire state for children under the age of 12. Less than 100 beds. But we've already agreed that prevention and early intervention works. So, you see, we've got these contradictions coming at us left and right. The other challenge about inpatient beds is our communities. You know, NIMBYism, not in my backyard. I don't want an acute psych hospital built in my neighborhood or near my neighborhood, because then we're just going to have crazy people roaming the streets and threatening our family members and reducing our property values. We have opened 700 new inpatient psychiatric beds since 2013. We have 700 more scheduled, but we're having a hard time with local zoning ordinances. It's not an OSHPD problem. It's not a lack of desire. It's getting past our community obstructions that are keeping us from getting those other 700 beds open. So I'm not ready to say the solution is more inpatient psych beds. I think that the consumers and the consumer advocates still are very hyper-focused on voluntary treatment only. So they're certainly not supporting more inpatient psych beds. Sometimes they support it when our emergency departments are saying, you got to do something. You got to help us get these patients out of our inpatient or out of our emergency departments. And sometimes the consumers then say, well, you just need to build more inpatient psych beds. Although we know that 70% of the people in our emergency departments don't meet the threshold or the level of care requirements for an inpatient psych bed. So, so we've got agreement, we've got disagreement. We're getting some science that's actually starting to support our efforts. And I would say that the science in the behavioral health field is, 10 or 20 years behind traditional physical health. And that's another area where the study of the brain and the mind is starting to get some momentum, and the more people talk about it. Let me ask our speakers to come up, and as they're coming up, I'm going to tell you some good news. One, behavioral health is on everyone's mind. As I was preparing my comments this morning in my room, had the TV on, of course, national news. So this commercial comes on, and it's a BDO commercial. And it looks like the lobby of a hospital, and it looks like there's a CEO, and it looks like there's a physician, and they're talking, and all of a sudden the screenshot goes to, well, merge with who? And the physician says, well, with a behavioral health practice. I almost fell out of my chair for national news to be talking about, or not national news, excuse me, a national station having a commercial from BDO about behavioral health. So that's almost nirvana for me. So I say that's progress, and I think we're going to continue to make progress. Good morning, speakers. So we're going to speak in the order that the panel is up here, and I'm going to introduce all three of you, and then I'll turn it over to you, Jeanette, to get started. Jeanette Lawrence Shea is a consultant with Price Philanthropy Foundation and focusing on grant making, and the Aaron Price Fellows Program. She has a BA from Cornell University, and then she started her career working on political campaigns, including at U.S. Congress level. Prior to coming to Price Philanthropies, she was the senior leadership team at Family Health Centers of San Diego, where she oversaw government and community relations and development. Marshall in the center, Monchief, is the regional executive director of the Institute of Mental Health and Wellness for Providence St. Joe Health in Southern California region. He most recently served as the director of neurobehavioral health at Hoag Health System. And prior to Hoag, he served as the clinical coordinator for dual diagnosis programs at St. Joseph's Hospital. He is a licensed psychotherapist with a clinical specialty in the treatment of addiction and co-occurring disorders. And finally, Dr. Peter Curry He is the Senior Vice President of Program Strategy and Innovation at the California Healthcare Foundation. He is a licensed psychologist. He has extensive managed care experience, including developing behavioral health networks. And prior to joining CHCF, he served as the Senior Director of Clinical Transformation and Integration for the Inland Empire Health Plan, a public health plan serving more than 1.2 million Medi-Cal members in San Bernardino and Riverside. He also held an executive position at Loma Linda University Healthcare and Psychological Health Resources. He holds a bachelor's degree in psychology from CSU Northridge and a master's and doctorate degree in clinical psychology. So please join me in welcoming our panelists. Jeanette, we're going to want you to come up here to do your presentation. Jeanette will be our first presenter.
Good morning. It's really an honor to be in front of all of you today. So I want to talk a little bit about the work that we're doing at Price Philanthropies around mental health, but also I probably want to just start and say at Philanthropy, we're just really here to be a partner, and we acknowledge that the folks that are in the room and the providers on the ground are really the heroes that have to do this work. I know from my time at Family Health Centers and then switching to the foundation, it is much easier to be on the funding side than the doing side, and we really honor the work that you do every day with the families. So our goal at Price Philanthropies is really to see if we can support work that puts kids' needs first, and so we've developed an initiative that hopefully supports some of the work around mental health. I would say that I just wanted to start with the current reality. If you look at the way that our mental health system is structured, it is just confusing. I mean, if we would start the system today, we would never set it up this way. And I know in my family, as we've dealt with some severe mental health issues, and as I've helped friends and loved ones and community members, anyone that tries to explain these differences, there's just eyes glaze over. So, the fact that we've divided up mild and moderate and severe, and we have one system for adults and one system for kids, and Medi-Cal funds some things, and, try to explain to the teaching staff that that kid is depressed because it's situational, so that doesn't qualify for the services here. But if it was more systemic, it doesn't really follow the heart of what's going on, and it makes it a big challenge. And I would say that, in my opinion, the root of all of this problem is that our mental health system is designed around money and payer sources. It's not designed around the people in need of care. And I think that is our biggest challenge going forward, is how do we address that? So, these are just the goals of our mental health initiative at Price. So trying to minimize these barriers, increase the capacity and quality of pediatric mental health services. Our foundation is really focused on youth, and so many of our mental health things are focused around the youth mental health system, although we fully acknowledge that most of the time youth are just a symptom of what's going on in their family, and you certainly can't treat children without addressing the needs of their parents, and wanting to improve the effectiveness and coordination within our system, especially in City Heights, which, as many of you know, is sort of Price's main focus area. These are a few examples of some of the projects that we have funded. This is just the beginning, but I wanted to share some of these as sort of first steps that we hope will make a difference. Price funds the difference to make sure that there are full-time school nurses and social workers in 3 Hoover cluster schools. This is an area where we've really focused at Rosa Parks, Monroe Clark, and Hoover High School. Schools are really the center of where our kids spend their day and their families, and boy, what a difference when there's a school nurse and a social worker that can spend the time helping that family navigate systems of care. I don't think this is a reality that will be in all of our elementary, middle, and high schools, but it is a barrier to getting our kids access to care and catching kids early when they're having problems. I would say that in these schools, one of the positives is that, so many of the behavioral issues, the acting out that we see with kids in schools that are getting away often have a root in mental illness or something going on emotional with the kids. And, when you have a social worker that can spend the time digging, it really can help identify that rather than just leading to a discipline track. A project we're very proud of is a new partnership we developed with Rady Children's Hospital in Mid-City. They have a behavioral health urgent care. So every day between 4 and 8, there is access to walk-in mental health services in Mid-City. And it is staffed by a psychologist and a psychiatrist. One of the challenges we found, particularly in City Heights, is that with so many of the kids that are on Medi-Cal county-funded contracts that have serious mental illness, they have like 4 hours of psychiatry a month for the whole contract. So if the kid or the family missed that appointment or missed that hour, they could be a month away from getting access to a psychiatrist for their meds. I know everyone will tell you in those contracts, well, if it's an emergency, we can fit you in, but the truth is there really is a limited access to psychiatry. And we heard, particularly even from CPS workers and others, they had kids where they were transitioning from foster homes and they needed a med check and they didn't have the prescription and they just couldn't get them into psychiatric care except by taking them into the ER, and certainly that is not where the child belonged or a good healthy setting. So the goal of the urgent care is really to be an easy access point, that when the family decides something is hopefully starting to escalate but not all there, they can get access to care. There is a full-time social worker at the urgent care, and that person's job is to work the following day, the next few days, the next few weeks, to connect the family back into a permanent behavioral health medical home. So the project started just about a year ago, and we've certainly seen a ramp up in the numbers and utilization of their care. They have had patients come all the way from Riverside and North LA County because they couldn't get into a psychiatrist up in LA. Obviously, the goal of urgent care is not to be serving LA kids, but I think it goes to show just the need for access to care. And so that project will continue. It's a 5-year grant on a slowly, grant high third-party payer ramping up with the goal of it being sustainable after 5 years. We also funded a grant to Sharp Mesa Vista for the renovation of their child and adolescent CAP unit program, and I know that construction project is underway. We've got some Sharp staff here, and just really excited to have a different environment for those kids, and know one of the challenges in mental health as well is that just the payer sources and reimbursements often don't lend itself with enough money to make the investment in the physical space that we need, and we believe philanthropy can play a role in creating those healing environments. San Diego Center for Children has a grant, and this is one that has a personal passion for me. I really wanted to see if we could do something where we moved all of the money on the back end so the families could just sit still, so that mom and dad could be treated in the same place the kid is treated, so that if the kid moved between mild, moderate, or severe, or mom and dad moved between mild, moderate, severe, it just didn't matter. It was one door, one place, one therapist that knew the whole family. I think there's so many times we waste so much money and resources and time by having families start over so many times without really addressing everyone together. So the San Diego for Children really wanted to tackle this in their Family Wellness Center, merging payer sources on the back end. Some of it's coming through the HMO contracts, some of it's coming through their county contracts, some of it's coming from a separate billing system that they've worked out with the county. Some of these have been moving targets. We'll see, jury's out whether they can make the money balance. It is a big challenge to take it on. But if a county-funded mental health provider that is not an FQHC, FQHCs have an ability to do this already, but if someone that's outside of the FQHC system can figure out a way to see a whole family together, I think we would have a huge model that we could expand in our community that would be great for families. And then the final project we're working on, much of our mental health for kids through the County of San Diego is school-based. Those contracts, the providers are at the schools. We actually went to the county and said, if you wanted to work on something in improving your system of care that you don't have money for right now, that philanthropy could support, what would you do? And the number one thing that came back was really communicating, linking the school system with the county contractors. And so we have a program that seems simple, but truthfully is just all about communication, referrals, linking families, making sure the behavioral health staff is connecting with the school staff. This is made incredibly hard by the fact that there is significant turnover on both of those teams on a regular basis. As many of you know, the county contracted mental health providers for kids, the way that they're funded, they're often staffed by interns. that are serving the kids. So there's every 1-2 year turnover of all the staff on a campus. It's the attendance clerk or someone else in the school, and we needed a more systematic way that those entities come together and know what each of them are supposed to do. Why I think this project in particular matters to you as hospitals is that when you're doing discharge planning and other things, this is the system you're trying to discharge your kids into. And if the families can't figure out how to access it, the behavioral health providers can't figure out how to pull the kids out of class, you're going to get them right back again. And the school-based system is designed for kids with the most serious mental illnesses. So anyway, anything we can do to make this work better, I think ultimately, hopefully, will help you all. So again, these are the challenges I think that we certainly have not solved, but we're working on of how to continue to move and blend the money on the back end. This second bullet, I think, is just one of our greatest challenges in San Diego. The truth is that no one person is responsible for the whole continuum of care. You know, I mean, and you hospitals, you play the backstop to all of this. You know, if an organization that's somewhere in the middle of serving mild to moderate, if someone threatens suicide, you know, the easiest risk-averse thing for them to do is just bump it to the hospital, when that may not at all be what the family needs. But if no one is really responsible for that whole continuum of where the kid stays, if there's constant bumping, it's very hard to make sure that we're doing what the family needs at every step. And then the third thing, you know, making sure that we're really aligning provider expertise with acuity and need. You know, the fact that we've got interns serving our most severe kids. We've got the more experienced licensing staff contracted through the plans for the more mild and moderate kids. And we've got hospitals as the backstop for it all. I think if we were really honest and looking and starting from scratch, we might realign which providers we put with which population and have some better results. I just wanted to mention on the, in terms of opportunities ahead and things we're thinking of price, I'll start by saying we are open to ideas. So I'd like to extend an open invitation to all of your systems of care. If you have ideas or thoughts about how philanthropy might support your projects, I am certainly open to hearing them and taking them to our board for consideration. A personal plea for the folks in the room is I think there is so much room for improvement in our discharge planning and support. As a family member that's been on the other side of this a few times, it is an incredibly hard process to be on as a family member, and while we may call them warrant handoffs, they feel very, very cold. And because the system is so disjointed, on the other end, you know, you get handed a list of 10 places, and the solution is often we can see you in 3 weeks. And that is no solution to a system of care for someone coming out of an inpatient setting. So I guess my personal plea is anything that can be done on the hospital side to really assist connecting families and kids after they're leaving the hospital. You could make such a difference in these families' lives and the stress that they're in some of the most awful moments of their lives. I think in terms of capacity in San Diego, we have no intensive outpatient program for youth. So we go from inpatient to the once a week at best, often twice a month, outpatient visits in a school-based setting. And something in the middle, I think, would be incredibly helpful for our youth and families. I think we really need a little bit more on prevention and early intervention with our adolescents and middle schoolers. We're seeing just, you know, a huge increase in stress and anxiety. We're doing some work at the high schools, but ideas in that area I think would be very welcome. And then obviously, like everyone, we are very aware of the provider shortage that we have, child and adolescent psychiatrists. We've heard some ideas around child and adolescent nurse practitioner programs as a possibility for extenders. That I think is an idea, if done right, could be very helpful in our system of care. At Price, particularly because we're focused in City Heights, we're starting to hear a lot from the refugee community that they need providers that speak their language, that understand their culture, that can work in their systems of care. And I know with the UCSD system, with the San Diego State system, with USD, we are so rich in educational resources. There has got to be a way that we could increase the culture and language diversity of our providers if we came together for a plan. So with that, I will stop, and I have my contact information there, and I look forward to a continued dialogue.
If you could come up here while we're working out this logistic, I have a couple of questions. So you talked about the warm handoff being a bit cold. Has Price, or do you know of anyone else that is contemplating an inventory of the resources that are available? Because in order for us to do the handoff, we'd have to know that for a hospital, to do the handoff, we would have to know what there is available. I'm going to trade places with you.
We've had quite a few dialogues around this issue, and I would just say I don't have the answer to it. I hope that there's some folks in the room that might have the answer to it, or together we could find it. The county answer is at the Access and Crisis line, and 211 has that list of resources. The problem is that's a list. How we find real-time information to when somebody has an appointment, it seems to be the crux of the challenge. So I guess that is a system challenge for us to have. I mean, a list of providers is not the answer. A catalog of providers is not the answer. Really is, where could you be seen, when, how? That appointment is the answer. And how can we support you and your family in the meantime? I mean, I think we need to be real that we're always going to have limited psychiatry resources. It's not realistic to say they're going to see you tomorrow, but perhaps there's some sort of social work or network or system that can be there in the meantime to support family and give them guidance until they get there.
Second question, you talked about there's not anyone responsible for the continuum of care. Who do you think should be? I don't have the answer either. It's okay to say you don't know. I don't have the answer either, but.
You know, I don't know if I could say that globally for San Diego. You know, we've had some good conversations with Sharp and Rades and others on what that might look like. Even if we piloted taking just some of the county contracts that hit on the kind of mild, moderate, earlier interventions to the crisis acute and just put those teams together somehow differently would be a great first step. You know, I think about some of these folks that are out in the community doing the therapy and care, how isolated they must feel when they really need the expertise help. You know, the compassion and the intelligence and the knowledge base that sits at our inpatient pediatric units, and I'm talking about pediatrics just because that's been the focus of our grant making. You know, how can they be available to maybe support that staff that's at the schools before they kick the kid to you, to knowing? You know, the head of the Rades inpatient unit told me, you know, no one gets healthy in our CAP unit. They get stabilized, but no one gets well. No one gets mentally helped well. And that thought has just sat with me, that is so true. You know, people get well in their families and in their homes and in their communities. But sometimes I think we have so many of our great resources are stuck in that unit, so we have to keep pushing the kids there.
That's a good answer. Let's open it up to the floor and see if there are any specific questions for Jeanette.
Good morning. I don't have a question, but you gave me an inspiration in thinking about mental health, and I'm from UC San Diego Health, Chief Clinical Officer. But you know, we have our patients every day in Hillcrest in the emergency department because we don't have beds available, limited resources. But you know, it goes back to, you know, you talk about physical health, we can all relate. But with mental health, it's still the stigma behind it. And I think it starts, as you say, with our families, our communities, that early recognition, because with mental health, there are signs, but you can't see it. And as you say, you know, sometimes it goes away, whether it's depression, anxiety, but other mental health stay with you. It's how you can cope and get the right help, whatever. But it's the whole approach to mental health is still that stigma. Yeah. And I think about the ED, you know, we put those patients in one area and we don't look at it as a disease, a condition, whereby, you know, with all other physical, you know, we have an orthopedic unit, we have a cardiac unit, But we don't have units that are really specialized in depression, anxiety, schizophrenia. They're all put in one area. So even on the inpatient side, we're limited of how we really care for, and I mean care, for these patients, no matter what age they are. So it's really a dilemma, but I think massive education has to occur. What is mental illness all about? And how as a community we support each other? Because as you say, I would say everyone in this room has been affected by someone or themselves that have had mental illness.
Well, and I would just share a personal experience from my family of, sometimes when you're in this moment where you don't know what to do, if you could get access to a professional just to give you guidance, and through my professional connections, our family is pretty resource rich, and when I finally could get to someone that could just give me some advice, don't worry about that, or just focus on that today, or this is what to do if this escalates, or this, it was so calming. It was like, okay, now we got it. We know, we felt so like, what do we do? And that's our family, that everyone has a college degree, everyone's employed, we had health insurance, but it was so hard to find anyone that would talk to me, that would really give me advice. Everyone was kind of like, oh, well, we can get you an appointment. But that appointment was 2.5 weeks out. I needed advice today. And someone's saying, if it gets bad tomorrow, call me back. And I think about that. We don't really have that in our system of care. And that wouldn't be the hardest thing for us to put in place, of somewhere where we could get that advice. So anyway, that's my final thought.
Great question. Is telepsychiatry a realistic option? I think you answered it if we just had someone to call. But telepsychiatry, I'm going to just sort of punt a little bit. Telepsychiatry just doesn't have to be with a psychiatrist. And I think that we tend to get that a little hyper-focused, that it's got to be at the physician level. Having access in a crisis for advice, I think telepsychiatry plays a huge role. Your comments?
I would agree with you. The person that helped our family wasn't a psychiatrist. It was just an incredibly experienced social worker that had dealt with 100 of these situations, or probably thousands of these situations, and could guide. So.
Hi, I'm Catherine. I'm the CEO of the National Alliance on Mental Illness here in San Diego. And this is all about partnerships, and we partner very strongly with the county and some of our hospitals, UCSD in particular, Scripps Mercy. And to comment on what you were talking about having somebody available to guide you during the crisis situation, is a large part of one of our programs called Friends in the Lobby. So in 10 of the behavioral health units, and now newly in Radies, we have volunteers that have lived experience, their families and caregivers, just for that. Somebody brings a family member into the emergency room and they're like, gosh, what do I do next? They have no idea what to expect if there's an admission for their family member, nor what to do once the patient may not have to go home with them as well, and where the resources are. So for community partners and all the hospitals in this room as well, please reach out to us. We are a wealth of resources and knowledge, just to be advocates and educators, peer support programs, so we don't have to walk this journey alone and not have the answers that really families need in a time of crisis.
Thank you. And does San Diego also have a family-to-family program?
We do. We have family-to-family. We have peer-to-peer. We have a whole host of programs, but and we're one of the largest in the United States right now for what we do. So to come visit us, please contact me.
Thank you. The family-to-family program that NAMI puts on is just phenomenal. So thank you, and thank you for standing up and for being here today and as a partner. If there are no more questions in the audience, we're going to turn over to Marshall. Okay, Marshall, you're up.
Hi, guys. So that was great. Thank you, and thank you for your questions. I was kind of coming out of my skin right then, not wanting to jump in and comment on every single thing, but it certainly stimulated a lot of thoughts. So with the question that Cherie asked to Jeanette, who's responsible for this continuum? I have an answer for that. It's every single one of you, and I mean it really, really adamantly. If you're in a hospital system, or you work adjacent to a hospital system, or you're breathing oxygen within this community, then it is your responsibility We're all impacted by it, and it won't get better until you lean in. So I'm from Orange County, that's where I live. The scope of my work is LA and Orange County in the high desert. I'll speak a little bit today about an Orange County perspective. For the last many years, I have been a participant in a health system that's pointed fingers at the county and everybody else for foreclosing on their responsibilities. We've whined and moaned and complained for a long time, and it's gotten us nowhere. And so we're trying a really new approach. It's sort of revolutionary, where you sit down with the people who are struggling with this challenge alongside you and extend your hand across the table and try to hold hands in this thing. And it seems like it's going somewhere. So I'll talk about that a little bit. And then another quick comment just on something that was brought up with Cherie and Jeanette with regards to more beds. Cherie was calling out, statistically, when you look at the numbers, so per capita, how many beds we need versus how many we have, there is a case to be made that there's more that there's a need for more beds. I agree with Cherie. More beds aren't the answer, because just like Jeanette called out, what happens in a bed is a MASH unit. I run them. The person gets stabilized, it's a valuable asset, but they don't get well there. And the number of beds that a community needs is contingent on the alternatives you have that exist and are effective upstream. And so that's where we need to be focusing our attention. And there's a little bit of momentum around that in Orange County, and I'm so grateful for the invitation to come here and share a little bit about that. We have by no means gotten close to solving anything. We're infants in this, but there is some hopeful progress. And then the last real quick comment on something that was just discussed with regards to telepsych, and is that a viable option? The answer is yes, yes, and yes. And Jeanette called it out beautifully. This doesn't need to be psychiatrist-driven. In fact, it can't be. We need to start as health systems positioning our valuable asset of psychiatry as quarterbacks of teams. That's the way we can get them top of license and have a distributed model of leadership. So anyway, I had to get that stuff out. So this slide, real quickly, just provides a quick context from my organizational worldview. I won't hang on it for very long, but I did want to sort of cue it up. So I'm from Providence St. Joseph Health. Some of you are aware we're a recent affiliated health system, now the third largest not-for-profit health system. So we got big quick, and man, we can hardly keep up with the ground moving under us. I was sharing with Cherie earlier that the challenge that we're all having is those of us geeks in mental health got what we've been whining about. We finally got attention and resources, and man, it's moving fast. So these are the 4 spheres of activity that I function in right now, the largest of which is the Well-Being Trust. Some of you may have heard when Providence and St. Joseph merged about this big $100 million thing. Well, the sisters are very active in our health system. And when we talked about coming together, they made very sure we weren't just doing it to get bigger. And so what are you guys going to do with it? And so they sort of put a stake in the ground, claim something, and take ownership of it. And so we claimed mental health. And we put a $100 million stake in the ground around that to lift this new not-for-profit entity called the Well-Being Trust. It was birthed of Providence St. Joseph Health, but it isn't Providence St. Joseph Health. In fact, we're very much trying to get it distant from us in order to attract other health systems and other partners to invest in this vehicle that can be used for advocacy at a national level, state level, and local level. And if there's some time, maybe at the end, I'll have a little bit of a moment to share with you about what we're doing in Well-Being Trust. The second sphere is our health system and the way we deliver care for mental health throughout our health system. So we've heard already this morning that the system of mental health is both disjointed and confusing. Well, within the health system I live in, the mental health delivery of care is disjointed and confusing. So we have a lot of work to do to streamline that and standardize it and get it coordinated. And then the third circle is the Southern California region. That's what I oversee. But what I want to talk to you about this morning is the Orange County Coalition for Behavioral Health. And it's all about partnership. public and private partnership, and how we create a unified system of care. So that's sort of the context for this thing. So in Orange County, so I'm going to get Orange County centric for a little bit here to describe this coalition. So within Orange County, I just stepped into this new role as of January of this year, and my charge was to help repair and unify a system of mental health care for the Southern California region. That was the charge. And as I started to reach out into the community and sort of take stock of what we had and what we didn't have and where things were, I was very much expecting to find what Jeanette and Cherie talked about, a dysfunctional system of care and a confusing system of care. And the good news is I didn't find that. The bad news is what I found was there is no system of care. So it's not that it's confusing to me or disjointed. It doesn't exist in Orange County. There is no system of care. This slide is an exact depiction of the system of care in Orange County. This is exactly what it looks like. And it's exactly what it feels like to a family. You're dropped in the abyss. And you can be a very high-functioning, well-resourced, and educated family. And man, when you step into the realm of mental health, you are in the abyss or on your own. Good luck. And so we've got a lot to do. The good news in finding that there was nothing here, there was no system, is that from a Pollyanna perspective, which I'm wholly committed to, this is a tabula rasa. And so let's get going. Let's build a system. We wouldn't have designed it this way intentionally, like Jeanette said, but if we could, what would we do? Well, the first thing we would do is we would design it as a whole system, a whole community. So we need a whole person, whole system, whole community approach to mental health care. And I'm just building on some of the eloquent comments by Jeanette, especially when you highlight kids and families within a school system. You need a whole person, whole system, whole community approach to this thing. And so we needed the whole orange, and we needed a coalition of the willing. I probably shouldn't have all the silly animation, but we needed to stop pointing fingers. So we extended an invitation. And so Providence St. Joseph Health and Hogue, who's an affiliated partner, we reached out to several people. The first people we went to are the usual players. So NAMI is at the table. John Lyerly and is leading NAMI with us. United Way, Jamboree Housing, I think they might even extend down here to San Diego. They came to the table as you would expect they would. The academic institutions came to the table. The faith-based community came to the table. And the public system came to the table in a really big way. And so emergency responders, county supervisors, city mayors, the Orange County Healthcare Agency, they're all there. And all of our health system partners, so all of the members of our HASC up north of you. So everybody came, everybody showed up, and we called it the Orange County Coalition for Behavioral Health. And we didn't know what we were going to do, quite frankly. We really didn't have a big agenda or plan. All we knew is that it wasn't working to keep pointing fingers, and so we needed everybody at the table to start building solution. This is about 9 months new. We came up with a vision statement. I think it's kind of clunky and could use some refining, but when you have all those people in the room that I just showed you, to get it sort of 80% is good enough. So we're going with this 80% vision statement, and at least we're moving towards sort of a common goal. And this was developed by the public system that was there and the faith-based communities, and everybody weighed in to come in up with this vision statement. These are our goals: access for everybody, fill the gaps, create a unified system of care, and try to become, as a collective coalition, a trusted go-to resource for mental health for the community. So when somebody is in the abyss, there is a one-stop shop that has NAMI representation. It has the faith-based communities. It has everybody there to get channeled to where you need to go. Some kind of concentrated funnel. That's the goal of this thing. And we've got three sort of buckets of thinking. So we're focused on, or where we target our efforts: the fires, the future, and the infrastructure. And so There are fires right now because of the lack of a system of care. So all of our emergency departments are packed, and we know the story, and that's reflective of the fires. We got to start addressing it, and it's not going to be by way of more psych beds. And then we need to focus on the future. We need to start focusing upstream on prevention and early intervention, which was talked about by Jeanette and Cherie. And so most of psychiatric illnesses emerge in the adolescent years, but most people don't get treatment for 7 to 8 years after it emerges. So by the time we get them, it's a red hot mess. It's a fire. So we need to move upstream. And then infrastructure is just reinforcing that idea of a whole systems approach to this thing. That's how we're focusing and targeting our efforts. The first thing we're doing is focusing on the fires because of its material impact on our ERs, because of its material impact on law enforcement, and because of its material impact on the families that need help. And so I'm going to talk to you a little bit about that specifically. So what we did is we organized ourselves, this coalition, into 3 work groups. And I'm telling you, it was completely off the cuff, coming out of the end of the very first meeting where we're all in a room together. And we all sort of looked around and said, does this seem like something we want to do? And everyone's nodding and saying, yeah, let's try this out. And our CEO, who you'll get to know more soon here, Rick Afable, kicked off just sort of off the cuff. Hey, why don't we organize into 3 work groups? And he called these names out right there on the fly. And we all nodded our head and said, that sounds good, let's do it. So we broke up into 3 work groups, and each person listed here took ownership as a volunteer chair for this work group. And everybody volunteered and split up, and off we went. And we would meet a couple of times a month, we still do, and about every 2 months we get back together as a coalition. So if it's okay, I want to spend just a couple of minutes walking through each of the work groups to sort of give you a sense of how this whole thing is coming together. So the System of Care work group. So we got together with the Orange County Health Care Agency and looked at the model of care that they had already sort of designed largely for the Medi-Cal population, and talked with our hospital partners, talked with the faith communities, talked with our emergency responders, and we all kind of came to drafting this high-level overview of what a system of care could look like and could include for Orange County. And it goes around the cycle, and you see the hub and the spokes, and so it doesn't always go in a perfectly clockwise motion for a person in need. And in the center is the very important elements of navigation. Housing is essential, and so our swim lane of mental health has to include long-term supportive housing and community support services. So this is a snapshot of the system of care that we've come to agree to. This is the playbook that we're operating off of, whether you're in the Orange County Health Care Agency or whether you're sitting in Kaiser or whether you're Rick Warren of Saddleback Church. This is the playbook we're trying to build. And we got the county supervisors buy-in to support this, and that's a trick. Focusing on the fires, on my slide it comes out pretty weak, but I think you can see it okay. Focusing on the fires first, we've got a 2-pronged approach: navigation and a crisis care ecosystem. So we're focused on the fires first. And so like Jeanette was talking about, you don't know where to go, who to turn to. We need navigation, and you need more than just a list of providers. And the county actually has a decent system. If you're a Medi-Cal, a person with Medi-Cal, they have OC links, and they have a web-based navigation system that's pretty decent. But if you're in the 75% of the rest of the community, you don't have this. So what we're trying to build is an app. Oh, there's OC links. We're trying to build an app right now that will aggregate all of the service providers in Orange County, no matter what sector you represent. And as you go into the app and identify in just quick clicks of a button your needs, it will route you to multiple easily accessible options. The app on the right-hand side was developed by the folks in San Antonio. If you haven't seen the San Antonio Haven for Hope, check it out online, and you might even consider taking a trip out there. we've had several trips out there at this point with our health system partners and some city leadership, and have been really inspired by what they've put together. And in many ways, it's influencing how we're approaching our work in Orange County. It's gotten such attention, and it has been useful to us such that a month from now, well, in January, the Orange County city leaders, I don't remember the title under which they're organized, but all the city mayors in Orange County, most of them have agreed to go out to San Antonio with us and look at this model to start to stimulate in them what can they do to contribute, largely around permanent supportive housing. But that's where we got this app concept, and we're working on building one now. Or we may buy it from them. This is the ecosystem of crisis care. So you see the up in the upper right-hand corner, that's our playbook. That's the wheel that we're operating off of. And so what we're working on right now is the ecosystem of crisis care, a component of that. And this picture is sort of what this thing's going to look like. In an ideal situation, these are all going to be co-located services. There won't always be an opportunity to co-locate just because of real estate availability and all sorts of other junk. But if we can have them in close proximity and coordinated, then we're getting somewhere. So on the front end is a triage, and then as you walk through the door, it's always difficult to differentiate what's psych and what's chemical dependency. Oftentimes it's both. So then you split off and get your needs met in a 23-hour crisis unit or a very low-cost 24-hour sobering station. The hope, now many people will leave after that. The hope is, though, we can capture them into either 2-week crisis residential facilities or a longer-term detox and then into a sober home. But none of this requires new acute licensed psychiatric beds. That's not what we're targeting here. And then intensive outpatient programs, again, to build off of Jeanette's comments. Such a valuable and underutilized resource is having a system of intensive outpatient programs, particularly for adolescents. And there might be some things we could talk about after this around that. El Camino Hospital up in Northern California under Michael Fitzgerald has done a phenomenal job of creating a model for adolescent intensive outpatient. We're replicating it. He's giving us the playbook, and we'd love to pass it on to the next group of folks. And then you see next to this little crisis ecosystem all of the support services that need to be aligned with a place like this. And then the most critical is long-term supportive housing. You have to have it, or you're not going to move the needle. That's what we're finding. We haven't done much with it. We're making a little bit of progress, so I don't mean to sit up here and claim victory. We're in the midst of it. But everybody we talk to and everywhere we turn, it's reinforced. If you don't get the long-term supportive housing piece, then that ecosystem is only a half-throttle solution to all of this. This is just a quick snapshot of what we're trying to accomplish. So let me say this. So we just left the system of care work group. So as we broke off into these 3 work groups, the system of care work group, with all of the various representation I described, public and private, created what we just showed you. That's what they came back with to say, this is where we need to focus, and this is what we think we need to start with. And the site development group then took that and said, all right, we're going to go find the facilities for you. We're going to go find the dirt and make it happen. And Cherie alluded to this a little bit. I don't know if you were talking about Orange County specifically, but as we went out to create crisis stabilization units, we had 2 false starts. We were absolutely naive, just puppies with our tongues hanging out. We thought, oh, this is great. We got the contract with the county. Let's go do it. Completely ignorant to how serious the NIMBY issues would be, the entitlement issues, conditional use permits. I mean, we just ran into the glass door so hard, but it was valuable learning. So in the site development group, a big win for us was Dan Young. I had his name up a minute ago, attached to the Hogue brand. That's because he's a Hogue board member. But the value Dan brings is for the last 17 years, he was president of the Irvine Company, reporting to Don Bren. And so he knows a thing or two about real estate, and he's got a couple of connections. And so Dan is moving beautifully behind the scenes and opening up all sorts of real estate opportunities that we would have never been able to do alone. And so the partnership gets reinforced at every turn. So these aren't exact locations, but these are general proximities of the crisis stabilization network that we're trying to create, building off of the existing crisis stabilization unit in Orange County, which has been there for decades, 10 beds to serve the needs of our 3.2 million person population. So that's why our ERs are pretty full, because we've got 10 crisis stabilization unit chairs for a population of 3.2 million. It's a crack up. I mean, of course there's going to be a massive problem. You have 10 beds for 3 million people. And so this won't be the end-all, be-all solution, but it'll certainly help as we start to build out this network of crisis units. And so that's the synergistic interplay between the site development group and the system of care group. System of care designs the thing, site development is going out to do the work, and the next work group is, sort of Haven for Hopes. We want to do those too. We'll see if we get there. The next group is the funding work group. And so the funding work group, the funding work group, we knew before this that I would get hooked. The funding work group came forward to say this coalition is really terrific. It's great to have everybody at the table, but we're never going to move the needle as a coalition. A coalition isn't a thing. It's just a big kumbaya tent, valuable in that respect, but we can't take action. So the funding work group, based on the recommendations of the other two, came forward to say we need to form a new company, a new 501c3, which we're doing. It'll be real by the end of this week, called Mind OC. And so we kind of liked the little double meaning of Mind OC. And that's going to have board representation of everybody that's at that coalition. And we are lifting it with seed money. So the Wellbeing Trust that our health system birthed is granting money through Providence St. Joseph Health to put into the bucket of this new co. Kaiser stepped up and said, we're with you. And so we have $1 million seed money for this little nonprofit to lift it. And what the nonprofit can do and intends to do is channel and braid together resources from all of the participants at the coalition to actualize those crisis units. So just a quick comment, and then we'll wrap this up. Many of our hospitals take ownership of caring for the community through community benefit dollars, right? And so we give out a good amount of money through community benefit dollars. When I stepped into this role in January and I was going out and kind of taking a scope of the land and seeing what was happening, I came to a really wonderful organization called Casa Teresa. They provide housing and substance abuse support for moms who are homeless or women who are pregnant and homeless. Fantastic organization. Within 5 minutes of meeting their CEO, I learned that they were getting community benefit funding from 3 of our hospitals, none of whom knew the other one was giving them money, and all of the money was being used for something Medi-Cal should have been paying for. And so we had the opportunity to get Cal Optima and the county into the room, and it wasn't that they were shirking their responsibility, just nobody had taken the time to put 2 and 2 together. So they gladly picked up the baton and are carrying that responsibility. And now we get to redirect those dollars to be more impactful somewhere else. But that's just within our health system. We had 3 hospitals unaware of how they were funding. There's no strategic thought to that. So we're hoping that NewCo can take community, Mind OC, can take community benefit dollars from Kaiser, from St. Joseph Health, from Hoag, and braid it together, at least with respect to the mental health field, and impact things that have some strategic thought to it. So I think I'm at the end of my time, and so I'll stop there.
So in trying to keep on schedule, we're going to postpone the Q&A for Marshall so that Peter has an opportunity to give his presentation, and then we'll open it up for group questions. So Peter, please come on up.
It's exciting to be here. I can't tell you what it's like coming from kind of a state perspective to a community. Like this one and be able to see some of the activity that's going on the ground in San Diego, and very excited about what Jeanette and Marshall shared. I think Marshall really got the sense of the power of a collaborative approach to change. It's a very difficult approach to change, so I applaud his efforts, and I know many have tried to create such collaboratives, and yet sometimes they just have a very hard time getting off the ground. So if there's any learning to be gained, we hope we can tap into you, Marshall, and learn how you got it off the ground. I'm going to talk about a little bit more of the state perspective. But my heart actually is here in the delivery system between plans and hospitals and clinics. I think that's where the most exciting work in the state is being done. That's where the innovation is happening. And I think by the time you're done, you'll get a sense of that belief in all of you that you're at the point where you can make real change. I really don't think you're going to get anywhere waiting for the state to change so that things will get fixed. I think you're going to have to fix things locally and teach the state what they need to do to change, to support and sustain that change that you make. Okay, so how are we doing in California as far as addressing behavioral health disorders? I think this is a telling place to start. It tells us that 6 out of 10 people with behavioral health conditions do not get any form of care for their behavioral health condition. Now, if we looked at physical health care, I think we'd find a very different picture. I think this is just a good baseline to say there's a huge discrepancy and a disparity in the way we've approached behavioral health conditions from how we've approached physical health conditions. And now we are recognizing and paying attention to the fact that we can't get our populations healthier unless we bring behavioral health into the healthcare fold and stop thinking of it as a specialty carve-out and start thinking of it as part and parcel of what health is really about. One of the issues that we've looked at California Healthcare Foundation is what's the workforce look like? And what's the distribution? And how is that laid out in California? Because all of you know when you go to find a rare resource such as a pediatric psychiatrist to see your referral, it can be very difficult and a long wait to get in that queue. So what does the state look like? And so what you'll see is that there's a real correlation between where there is serious mental illness and where there isn't behavioral health providers in that area. So if you look on this map, you'll see that the areas where there is the highest prevalence of serious mental illness is also the area where you'll find the highest poverty rate, and it'll also correlate with the area with the least number of behavioral health clinicians. So we are really out of balance throughout the state in being prepared to deploy behavioral health services given our current distribution of behavioral health providers. This is San Diego, done in 2016, and it just takes a number of licensed behavioral health providers, LCSWs, MFTs, psychiatrists, psychologists, counselors, and tells you about their how many of them per 100,000 population. And I think if you talk to most people that work in FQHCs and deal with not only the mild and moderate population, but also those in clinics that deal with the severely mentally ill, we do not have an adequate workforce in San Diego, definitely not in Imperial County, and that is something that we need to wrestle with together. So this is my question. I came to Medi-Cal about 8-9 years ago, kind of as a fluke. I was consulting in behavioral health. I'd always done commercial and Medicare in my career, and I stumbled on a Medi-Cal health plan, Inland Empire Health Plan, and they wanted to know what to do with behavioral health. So I went in and looked at it, and I was really astonished because there really wasn't a benefit for behavioral health for Medi-Cal. I think the state thought there was, because there was supposedly a fee-for-service network that you could access back in 2008. No one took Medi-Cal rates in private practice, so it really meant there was no access for anybody who did not get into the county mental health system. How many of the people that need behavioral health services actually get services through county mental health? By working at IHP, at least in the Riverside and San Bernardino areas, we found that after we took over behavioral health and started doing it ourselves as a health plan, that 97% of all of those that we referred to a behavioral health specialist went into our network, paid by the health plan, and only 3% of the population seeking or needing behavioral health services really met the severity criteria to get into our county programs. That meant that we really had no access up until 2014 when we finally got a parity benefit for Medi-Cal. I think that's an important thing to stop and think about. How long the poorest and the most vulnerable in California had no access to behavioral health treatment. 2014 is when we got the benefit. And I'll tell you, across the state, our access and the penetration rates don't show that we're doing a wonderful job since we got that benefit. I think there's a lot to be improved upon about getting behavioral health services more available to particularly the most vulnerable in California. So this is my question. Specialty care, or is it really segregated care? We made this brilliant decision back in the mid-90s when we formed the Medi-Cal managed care plans, that the county mental health system could become, overnight, mental health plans. And so we bifurcated our structure for Medi-Cal in the state into the system that took care of the severely mentally ill and the system that took care of the rest of the Medi-Cal population. And that was an unintended consequence of that decision, is that we had a healthcare system for Medi-Cal that grew up with no responsibility, essentially, for the comorbid behavioral health conditions that are embedded in their most vulnerable population, their highest need population, their highest cost population. That was carved out. And I think because of that, I bring up the word segregation, because it reminds me of the 70s, because I'm old enough to have lived through the integration of education, particularly in Indiana, where it was a big deal. And it reminds me of when we finally, as a country, became committed enough to make a very hard choice to say separate isn't equal. And I think that applies in healthcare now. Separate special systems for those people, either those people with mental health conditions that are severe or those people with substance abuse conditions, is not equal care. And that's definitely borne out by the fact of the mortality statistics for anyone treated in a county mental health system. And this is a national problem. They die typically 25 years earlier than the rest of the population. Why? They're not dying from schizophrenia. They're not dying from bipolar disorder. They're dying from comorbid, inadequately treated physical health conditions. And I think that's really the telling metric that says separate is not going to work when it comes to getting our population, particularly the most vulnerable, healthy. So this is just a description of the division in the state of responsibility because of our bifurcated funding stream. What the county mental health plans are responsible and for what the managed care plans are responsible for. So this is another way of looking at it. Again, health plans live in that area that's got the red circle now around it. That's what they provide. County systems are supposed to take care of the severe. Anybody see a problem with this picture? I don't know anybody that fits into these boxes over time, right? They don't. People are whole integrated people. Sometimes their symptoms are severe enough to be severe, and they would go to the county. And then guess what? People can recover, and they become mild and moderate. Now they have to go to a different system of care, and vice versa, and so it goes. And that's why this way of thinking about our population really doesn't work. So, what's the business case for dealing with this population? It really comes back to 5% of the population use 50% of the resources in Medi-Cal in California. So we've all heard of this. Let's deal with the high-risk, high-need population. But when you drill down into that population, you'll find that the comorbid, most common diagnosis is a psychiatric, a mental health condition. So if we're going to deal with cost of health care, and that means addressing that 550 population, we cannot do that separate from dealing with behavioral health. And I don't think having a bifurcated funding model in the state is going to get us there. So this is just more evidence of when you add a behavioral health condition to diabetes, this is the cost of care and how it rises. So you'll see if you had diabetes only, the cost is lower. By the time you get to the right-hand side, you'll see that if you have an SMI and a substance abuse condition added to diabetes, you have a very costly case. That's Dan Berwick, by the way, triple aim. It really is about taking care of the mental health illness. This is a spreadsheet of who's costing the most in the system, and when you add in any mental condition, it's the highest. Again, serious mental illness right up there. This is why we can't ignore this population. So what's the answer? I would say integrating care. We've talked about it. There are lots of models. There are lots of definitions. I would recommend, so we all get on the same page, that you look at this definition and maybe adopt it when you start talking about how do we go about integrating care. What does that really mean? Because actually nomenclature and definitions are important when you go to make change. So for people with chronic, complex conditions, this is kind of a way of looking at how do we deploy care and the different types of services and models that get deployed. And many studies tell us that care management really needs to vary based on the different populations that you serve. So we've got a well-established body of research that suggests that collaborative care, the kind of model where that Washington State adopted a number of years ago, where they embed behavioral health in their FQHC system to make available behavioral health consultation and services, is a cost-saving and effective way of treating those high-moderate population, those that need access to behavioral health but don't necessarily need to be referred out to a specialist but could be treated by a behavioral health clinician that's embedded in the team care that's happening in the FQHC. Oftentimes, the less severe can be successfully treated by primary care and self-management. I think this has a lot to do with our training of primary care doctors. How competent and comfortable are they in taking care of someone with depression, anxiety disorders? And when that comes up in their visit, do they feel like they have the tools and the understanding to address that need? And if they do, we're going to see a much more effective level of care for a huge swath of our population. I saw a very innovative program at UC Davis where they're taking primary care docs, a lot of them out of FQHCs, not taking them away from work, but taking them through a fellowship part-time for a year to retrain in psychiatry. And then those docs go back as it's kind of the train-the-trainer model, and hope spread their knowledge now about, a broader knowledge about psychiatry among their colleagues, with the hope of being able to enable physicians, primary care docs, to do a better job of taking care of behavioral health. And as a psychologist, I'm, quote, a specialist, but I have a basic belief that most of behavioral health belongs in primary care. It belongs in primary care because that's where people often go for help. They go as an integrated person, and their behavioral health condition is intertwined with their physical health condition. And if we aren't capable in that setting of being able to address both address the whole person, I don't think we're going to get there. The other thing I've come to believe, having done many arguments in the health plan world around what kind of utilization review needs to be done for Medi-Cal and that population. I would argue from day one, you need no severity criteria for a Medi-Cal member wanting to access behavioral health care. You know why? I've never met someone who's poor who is worried well and is going to overutilize the outpatient delivery system. They don't exist. You show me one. They're stressed. They have transportation issues. If you can get them to see a therapist, that's a success. Don't put restrictions and severity criteria on who gets to go. Believe me, if they go, there's a reason. So again, it's thinking about behavioral health as there should be easy access. It should be like we think about primary care, no specialty referral required. Any open door should get someone access to behavioral health. And we think of it more like accessing primary care than we would specialty care. So I'd love to see us start to think in those terms. At the very top, you'll see this is where you guys are, hospitals. This is where, guess what, SMI and SUD lives. That complex population is in your EDs. They're in your beds, whether they belong there or not, because that's where they go for care oftentimes. The ED is a one-stop shop for many of this population, even though you may not be equipped to deal with them. And you'll have a heck of a time trying to get them placed when you go to realize that they need treatment somewhere else other than your ED or in your med-surg bed. So I just want to show you quickly some examples of success, what I think are bright spots. I spent yesterday looking at a very bright spot in San Diego where the hospital has transitioned their IOP program, because Medi-Cal won't pay for IOP, to an FQHC system who's taken on that level of care. And they are now being able to successfully fill a gap in care that exists, particularly in Medi-Cal, because they don't pay for intensive outpatient programs. How many of you have seen a psychiatric patient go into a psychiatric hospital and guess what? Get readmitted within 30 days. In my health plan, the 30-day readmission rate when I got there was 35%. Okay? Obviously, something isn't working. The handoff to ambulatory care didn't work, and that's why we got this high readmission rate. So again, this was a creative solution. It didn't involve having to get county mental health to the table. It was a creative solution between an FQHC system that was willing and a med-surg hospital that was wanting to take the resources they had and infuse them somewhere where they could continue to live on. Very exciting to see. I want to tell you about some more around the state. I also visited a couple weeks ago an FQHC system in Sacramento called WellSpace. Very innovative. This is a FQHC system that started from a behavioral health platform and then went to a FQHC physical health platform. So they kind of had the advantage of behavioral health was always embedded in their DNA. And so they've been out there trying to meet needs. And one of those needs was, guess what? Hospitals in Sacramento, EDs, where they had the mental health and substance abuse clogging their hospitals. They also had a population where they had suicidal folks that looked like they needed a 5150 assessment, and that didn't work real well in the ED. And so what they wanted to do was figure out how can we help relieve this problem and safely have these folks, particularly those that have suicidal ideation, when they leave that ED, have a place to go immediately. And you know, the handoff is hard. If you don't have the resources to have a care manager take them physically, transport, oftentimes they drop through the cracks between leaving the ED and getting to whatever appointment you might have arranged for them. So when you have someone that scores on the PHQ-9 as having suicidal ideation and they're in your ED, this solution came up to them. Well, they redeployed and repurposed their existing behavioral health clinicians within their FQHC system to do case management for the EDs, by making a proactive outbound call to that patient who scored positive on the PHQ-9 suicidality score. It doesn't sound like a big deal, and it's actually only cost $60,000 for 4 EDs for a whole year to get this service. So the hospitals ponied up for it. They didn't have to go get money from somewhere else. It was just made sense. And guess what? Over that year, there were no readmissions within 30 days for those patients leaving the hospital and having a care manager call them. And again, it wasn't with a phone number. The care manager called the patient as they're leaving the room and started a relationship. They did daily calls to that patient for 30 days. And guess what? They didn't come back to the ED. Not only that, there has been no suicide attempts among that population. That's pretty exciting. That really relieves your ED staff from saying, if I can get this connection, I can actually go home tonight and feel like, okay, I didn't just send that person out into a void when they had suicidal ideation. This is just an example of what I would see as a very creative local solution in partnership between an FQHC system and a hospital, where they just simply are taking the resources already there and giving them a phone call and a protocol to call. Now, the cool thing about that is that's available anywhere. They could do that for your EDs if you wanted it, or you could just go learn from them. Very cool, bright spot. CHCN is a FQHC system in Alameda County, and they're a consortium, and they've taken the risk, the capitated risk for the Medicaid population in their region under that umbrella. Now they're working to take on the behavioral health, mild and moderate risk, capitated risk, and eliminate the carve-out, build their own behavioral health network, and thereby be able to integrate behavioral and physical care so they don't have to deal with getting an external auth every time they have to see a behavioral health patient. Very encouraging. That's movement in the right direction. Partnership Health Plan in the North. They're integrating the behavioral health funding stream first with substance abuse in 11 of their counties that they take care of as a public health plan. They have taken the financial risk from DHCS to take care of the substance abuse benefit that just got expanded. And so they're managing that for each of their counties, and then they're able to use the infrastructure of their health plan to be able to infuse resources and make sure substance abuse and physical health are provided in 11 of these rural northern counties. Why is this significant? Because remember that bifurcated funding stream that causes this disconnect in our world? They've taken a regional solution and say, let's blend that at the plan level and then be able to put substance abuse treatment together with physical health in a way that makes sense. That's a regional solution. Another example, and you have a pilot here in San Diego, is around community paramedicine. Anybody aware of that pilot? So it's all about alternative destination. Right now, a lot of your EDs get clogged because there are very strict rules and limits on what a paramedic can do in transporting a mental health patient, a substance abuse patient. They bring them to your ED. And there is a problem in that there may be other appropriate places for them to take them, like a sobering center or a mental health crisis clinic, but they've been blocked from doing so, largely by scope of practice. And so there have been a pilot authorized in the state, CHCF is funding it, to be able to experiment with, can we get some relaxed rules around what they can do, and then study this and see if there is a way to safely adjust what a paramedic can do, an EMS system can do in transporting patients. So again, kind of a bright spot. Don't know if it's going to pass legislative approval, but guess what? Most of the feedback is that most hospital EDs and even the ED physicians are not really resistant to this idea when it comes to substance abuse and mental health. Maybe some of the other population there's more resistant, but guess what? Most of you in this space really don't want this population clogging up your ED. So maybe you're going to allow them to go to an alternate destination that can more effectively treat them. this is where the pilots are and what they're focused on, and you can look into them a little bit more. You'll see the one in San Diego is a pilot around 911 and using paramedics differently. Okay, I am going to, in the interest of time, leave most of this because this kind of comes from what the Inland Empire Health Plan is doing, and I'd be glad to share more about it, but we launched Behavioral Health Integration Complex Care Initiative about 2.5 years ago, and it's showing some pretty astounding results. I'll let you go into the details on the project and the framework later. But I just wanted to show you this because I really believe as you start innovative projects, you really need to build in an evaluation that measures, guess what, ROI, return on investment. Sometimes with complex populations, that return may take 2 years, where you're investing and believing in doing better care, and it may even cost more for a while. So, but the CFO in the system is going to want to know, when does the bleed stop, and are we going to save money eventually? And so this is an example of the costs that they've tracked with what is a very expensive integration project over the last 2.5 years. So being able to demonstrate that kind of drop in inpatient bed days from the investment in the delivery system and transforming it through integration is speaking loudly. So lastly, I would just pose this question to you. We kind of know where we're at. We're at that middle space where we've got a lot of innovation happening, mostly on a regional basis, exciting movement. And I think that is going to happen in your partnerships that you form locally. And I guess the question is, will we ever create a tipping point for the state where they will finally wrestle with the bifurcated funding that is really at the root cause for the segregation we have between behavioral health care and physical health? In the meantime, it's up to you all to do workarounds around that structural problem, to be able to figure out how do you do things like Partnership did to blend their funding to do a more sane way of treating the substance abuse population. How do you actually, with your resources, come together and solve that fundamental problem until we can teach the state it's time to change that, and there must be a will to do that. So thank you.
Perfect, thank you. So we have about 3 minutes until the end of our program, and I would like to open it up to questions from the audience. I can see from here. So there's a hand in the middle of the right in the back.
Lots of questions, but I'm going to triage and just ask one. My name is Nick. I serve as the Chief Medical Officer of the county. And Marshall, I actually wanted to ask you to unpack a little bit more quickly, if you could, your potential ideal role for the faith community. It's interesting you mentioned Pastor Rick Warren up in Orange County. This is public record. He was activated because of the suicide of his own son. Obviously a very influential, quote-unquote, evangelical leader, but that's passionate about this. It just seems like a completely untapped resource to me, and wondering if in your idealized world, what better, quote-unquote, faith involvement across the spectrum would look like.
Yeah, thanks for that question. We see it similarly, that it's just a huge resource that's untapped. Some of the dynamics in mental health, and it's been touched upon by just about everybody who's spoken here this morning, is inherent in these illnesses is the difficulty to identify that there's a problem or reach out to get support for that problem. And so like Peter was referring to, you don't have to worry about overutilization, because if somebody's reaching out, it's because they're really sick. So the places they do tend to go, that people in need tend to go, are the places that feel most trusted and safe and intimate. And for many, many people, that's their faith congregation. And so it's really been terrific to watch Bishop Van of Orange County connect with Rick and Kay Warren and start talking together about how they can lift the resources of their congregation to help meet this need. One very specific idea that the Warrens are talking about is they've created these little peace centers. They're almost like that's what they call them, peace centers. And they're almost like this sort of a little informal FQHC, where they're providing as much support across any number of needs as they can at each of their church locations. So we're just kind of getting started with them and are sort of excited to see ourselves how this unfolds, but it's definitely an intention on the part of the coalition to reach out to all of the major and smaller churches and get them in the tent.
Thank you, Marshall. I don't know if this is an app question or just an audience question, but it's directed to Peter. Can you elaborate on your point about integrated care? With the current bifurcated payment system, who do you envision as the glue to bridge the physical and mental health needs? And if your answer is primary care, how can it be done? And you got a minute to answer, so you're going to solve the world's problems right now.
I don't know if my mic's working.
It is.
Okay. So I'm going to pass this question to Ian Morrison. He's a futurist, and I think he might be able to articulate the answer that has a likelihood. Actually, I do have some ideas about what that glue might look like. I do think that there is a workforce that is available in our county mental health systems. I think they have taken care of the severely mentally ill, and I do think they have not been utilized in an efficient way. I've seen the throughput and what happens to somebody going through that system and compared that to a commercial clinic or an FQHC, and believe me, there is capacity if they could be retooled a bit in the way they operate. So I'm not sure I would have a great deal of confidence of saying, let's turn over physical health to the counties, that they can run the whole show. I don't see that infrastructure being strong enough. I do see some bright spots, and I see more accountability when it comes to plans, particularly local Medi-Cal plans. The problem there is you have plans of varying capability, scale, and so not all of them are able to actually do this work effectively. Plus, in some counties we have 1-2 plans. Some counties we have 5, maybe soon to be 6, like San Diego, 7. That's very hard and cumbersome model to work with. So there's an opportunity. There's a process that DHCS is going through over the next year or so, year and a half, of getting ready to re-procure how the services that they buy from those local health plans. And as they go about re-procurement, could we breathe into some sanity into what should a health plan look like that could take care of the whole person, including the behavioral health care needs? What kind of scale, what kind of regional coverage should they have? And can we rethink and leverage some of the really good practices that have been brought up in the managed care system and be able to stabilize areas where maybe that is a weak spot? So at risk of causing great disturbance and among my colleagues, I would say that yes, there are alternatives, and I think for the Medi-Cal, I think given our political environment, I think it's a worthwhile focusing on, instead of just reinforcing the Medi-Cal system as if that is our only vehicle, I think we have to focus on the population Medi-Cal serves. What is the best vehicle to take care of our poor and vulnerable in California? And given all the uncertainty that's happened over the last years, I think there are some opportunities in this crisis to be able to rethink the models that we have now and to be able to make some significant and maybe disruptive improvements in that framework.
Thank you, Peter. Please join me in thanking our panel.